This podcast is brought to you by Big Motoring World, one of the UK's biggest used car supermarkets. For more information, go to bigmotoringworld.co.uk. Hello again and welcome to the Dr Hilary Show. Coming up this week, lung and skin cancers are the deadliest and most common cancers worldwide. My guest today is a leading consultant oncologist who specialises in both, and he'll be answering the questions we're often afraid to ask about cancer ourselves. He studied at Oxford, working on ways to target cancer treatments and boost radiotherapy for each patient with new drugs. I'll be joined by Dr James Wilson. First today, a reminder that the best health and wellness advice I can give you is to click our subscribe button on YouTube. Nothing is more important than your health, so do yourself a huge favour, click subscribe now, and in return I'll make sure you receive health tips that you can trust and rely on every week. Now to this week's guest, a leading oncologist treating two of the world's most serious cancers, lung cancer and skin cancer. From Oxford research to cutting-edge radiotherapy, James Wilson is here to demystify cancer care and answer the questions we're often too scared to ask ourselves. Welcome, James.
Oh, Dr Hilary, I'm overjoyed to be here.
Oh, it's great. Thank you for your time.
I can't tell you. I think you taught me more medicine of my first 2 years as an undergraduate than any of my lectures ever did. So thank you for that.
Oh, you're the one that was watching. It's fantastic.
Well, I definitely wasn't taking notes.
You're a specialist now, a specialist oncologist, and dealing with some of the biggest cancers that we face.
Yes.
Particularly lung cancer and skin cancer, and others besides. Lung cancer, the fourth commonest cancer still in the UK, globally probably the most common, I understand.
Absolutely, and the leading cause of cancer-related death. I mean, that's something we don't talk about a lot, isn't it, as a society? We don't talk about death very much.
Sure.
But, and the thing that excites me most about lung cancer is even from when I was a medical student to even a junior doctor in Essex on the ward, telling somebody they had lung cancer, it was always a bad news story. Yeah. And now we're able to offer people curative treatment more than ever before because of so many successes in both the treatments we can offer, but also detecting the cancers earlier. Yeah. But also the treatments for people who have late-stage disease, a million worlds away from where we were even 5-10 years ago.
We're, of course, better at early detection. So we've got mobile screening units. People are more aware of the symptoms. We talk about it more. Yes. It's not hidden away. We don't have to wait for people to start coughing up blood. Yeah. You're seeing a lot of patients with lung cancer. Are you seeing them earlier?
Absolutely. So I'm really lucky. So I was a consultant at UCLH, which led a lot of the work that led to the current NHS screening programme that's been rolled out. So a real beauty of lung cancer screening. So if you're age 55 or over and you've got a smoking history and your GP should have you on their records, you will be called for a screening test. And please, if you are called for it, please do turn up because the earlier we detect your cancer, the more likely we are to have a success with your treatment. And just to give an example, so if you wait to have symptoms to have a scan to have a lung cancer, 75%, that's 3/4 of those people will have an advanced incurable disease. However, if you turn up for screening and you have a low-dose CT scan to assess your risk of lung cancer and we find something, there's a 75% chance, so that's 3 out of 4 chance you'll receive curative treatment.
Right.
So that's
such an important thing. Get screened if you're a smoker in that age group. And the screening involves a chest x-ray or a scan?
A few questions to assess your risks based on your age and smoking history, that kind of thing. And then a very low-dose CT scan. Yeah. And that gives us enough information to both decide if there's anything going on now that we need to act on, or to call you back, and how frequently we should call you back for scans in the future.
And just remind us, what's the risk if you've been a smoker most of your life? How much more of a risk are you at
smoking's a huge risk, isn't it? I mean, I can't see any benefits of smoking. And when I meet a young person who smokes now, I just find it baffling. Yeah. The evidence of the risk of lung cancer, coronary artery disease, all of these negative effects of smoking have been around for ages. Yeah. So please don't ever pick one up.
No, absolutely. But the smoking situation in this country has got a lot better. Yep. It used to be 45% of people used to smoke, back in the day, and now it's 14?
It's around there, isn't it? It's like 10-14%. Yeah. That's where I
So it's getting better still. So the things that we've done to change public health policy, banning smoking in certain places, has really helped.
And that's a real hot topic at the moment, isn't it? With the tobacco, vaping and tobacco ban. I mean, I was chatting to somebody about that this morning, and I think, in 50, 100 years' time, that's going to be seen as possibly the biggest health intervention of our generation, isn't it? So if we stop new people being able to pick up a tobacco product and getting addicted to it, we're going to have generations from now on who never smoke.
And then, and absolutely. And the next thing will be obesity, dealing with that epidemic. Where do you stand on vaping? We mentioned it just there.
Yeah, so vaping's an interesting one, isn't it? So absolutely, don't do either. Don't smoke cigarettes and don't vape. But if you are a smoker of cigarettes and you can see vaping as a bridge to getting off your cigarettes, I think it might have a role there, but as a stepping stone to stopping.
Absolutely. So it's still considered much safer, but nobody should be inhaling anything other than pure fresh
air. That goes into that.
Oh, yes, indeed. Yeah.
I mean, why would you put that into your lungs? Again, something else that baffles me.
Propylene glycol. It doesn't even sound nice, does it?
It doesn't.
Inhaling it is the propellant. No, that's right.
No, it's interesting. I mean, so the ban that's just gone in is interesting, isn't it? That's stopping the sale. That's the 1st of June, so that's just coming up, isn't it? So the banning of selling of the disposable vapes. So that's really helpful in terms of the environment and the waste disposal risks of that. But then it's the second bill, which hasn't been passed. It's going through the House of Lords at the moment. That's going to ban the promotion of tobacco products and also the vaping in public areas, a bit like the smoking ban. But I think the important thing is if if this bill goes through, which I really hope it does, if you're born after the 1st of January 2009, you will then it'll be illegal to sell you tobacco products. I mean, that's a really bold move, don't you think?
It's a real bold move. Not as bold as the Australian government's move that said you can only vape if you've got a prescription. They've revoked that now, but I thought that was a really good, if you've got a prescription to give up tobacco, that's a good way of...
And it's a way of getting you into the services to support you, isn't it? I mean, because some people, and I see lots of people in my clinic and they ask me, look, I've got cancer now. Is there any point in me stopping smoking? The horse has bolted.
Yes. I
say, well, actually, yeah, because if I'm giving you radiotherapy for lung cancer, your outcomes are going to be better in terms of cure if you stop smoking. And also the side effects are going to be reduced if you stop. And actually, some people in that situation, it's a very stressful time. Cigarettes are often their only way of coping with that stress. And it's a way we have an opportunity to teach them new mechanisms of dealing with uncertainty and difficulty.
Absolutely.
And tap them into the right services to get them the medications that can help stop smoking.
Now, there are different types of lung cancer. Smoking can increase the risk of certain types more than others. Tell me about the different types broadly.
Yeah. So there's two main types of lung cancer, and we split it down the middle into small cell lung cancer, which is slightly rarer type. So about 15% of lung cancer is small cell lung cancer, and non-small cell lung cancer. And non-small cell lung cancer is an umbrella term for lots of different type of lung cancer. Now, small cell lung cancer, I often think of it as more of a systemic problem. That means that it can spread through your body a lot earlier than non-small cell lung cancer can. So it's a lot more aggressive. So the drug treatments or the treatments that I give for that tend to be more focused on drug treatments. Then I add in radiotherapy to consolidate or make stronger the response to those drug treatments. Non-small cell lung cancer is where we've seen the biggest developments in treatment. So, one of the challenges that I have when I meet somebody who's just been diagnosed with non-small cell lung cancer, particularly if it's at an advanced stage, is sometimes I have to say to them, look, we're going to have to put the brakes on for a little bit because we need to find out if there's a genetic driver of that lung cancer. Now, the beauty is if it does have a genetic driver, then we've got so many more treatments we can offer them. And I've got patients in my clinic who have an EGFR mutation, for example. And if you have an EGFR mutation, we have tablets that you can take at home, which you take at home every day. And that keeps the cancer it will shrink it down, it will control it, and it will contain it for a period of time. And increasingly, I'm offering people very highly focused, very high dose radiation to the cancer when it stops responding to that drug treatment. So it keeps you on that treatment for a lot longer. For example, if you had metastases or spread of the cancer throughout the body and the tablet's controlling most of them, but maybe one or two areas start to grow again, we just zap it with radiotherapy.
Okay. And would be that stereotactic, proton beam, different types of radiotherapy?
So if you've got very small spots of cancer that you're trying to eradicate completely, you need something called stereotactic radiotherapy.
Right. And just explain that.
Yeah, so stereotactic radiotherapy is using a very small number of treatments. So when people think about radiotherapy, they think they're going to have 7 weeks of treatment where they're going in every day. So if I meet somebody with an early stage lung cancer, so a small spot in the middle of their lung that we've confirmed as a cancer, I give them anything between 1 and 5 fractions of radiotherapy. So when I was a medical student, to tell me that I'd be curing people's lung cancer with a single treatment,
Wow.
I wouldn't have believed them.
No.
I mean, obviously, that's a very involved treatment. So again, people, a point of anxiety with that is the first thing we do is a planning CT scan. And then it can sometimes take a week or so, sometimes even 2 weeks before we give that treatment. And then when it starts, it's a small number of treatments. The treatments take a little bit longer than standard radiotherapy, because if you imagine, if we're giving very high doses of radiation with pinpoint accuracy to very small areas of the body, the things like the setup of the patient, getting them in the right position, doing scans of the patient while they're on the radiotherapy treatment couch, that takes a little bit longer, but the convenience is it's 1, 3 or 5 treatments to get rid of your lung cancer forever.
And you mentioned gene mutations there. Is this what we call personalised medicine, targeted medicine? It's the individual that is taken into account before they start. It's not just blanket treatment for one size fits all.
Yeah, so there's two points in a patient's journey where I will look at that personalised genetic signature of their cancer. And one thing just to highlight here is sometimes people think, oh, I've got a genetic mutation. This is something I can pass on to my children, so I get them checked. And that's often leads to quite a fruitful discussion, because the genetic mutation is just in the cancer. It's what's led to the development of the cancer. It's not in every cell of your body. You can't pass it on. But that personalisation is so important. So we do it right at the beginning. And I'll be looking at the genetic signature and deciding which treatment is best going to the key for the lock. So if you imagine there's the driver is a protein in the cancer cell, and we've got a key that will block that protein to stop it signaling to the cell to continue to live, continue to divide, and potentially spread. So that's what the drug does. The next time I will do it is if the cancer progresses, I don't think, oh, well, we did the genetic screening and the personalised medicine before, we do that again. Because if there's a good chance that the genetic signature could have changed, and you may find out that you've got a whole new panel of drugs that you can use to target that genetic change that's evolved. Because the reason it's escape control of the first treatment is because the genetic profile of the cancer has changed.
And I know that, talking about the drugs that we now use, combinations of maybe a monoclonal antibody and something else can halt progression for longer compared to treatments that we've used in the past. So there's progress there all the time, isn't there?
Oh, absolutely. So if you look at something like chemoradiotherapy for non-small cell lung cancer. So if you've got stage 3 lung cancer, that's usually either a large tumour in the lung or a lung cancer that is spread to the lymph nodes, either at the root of the lung in the hilum or in the middle of the chest, what we call the mediastinum. If you're having chemoradiotherapy for that, you get a combination of all 3 of the main treatment groups. So you're going to get chemotherapy. Alongside your chemotherapy, you're going to get radiotherapy. And then at the end of that, you're going to get a year of immunotherapy. So immunotherapy, drugs like durvalumab, they will encourage your immune system to recognize the cancer cell and destroy it. And we know that if we do that, there's probably a 10% survival advantage. So you're 10% more likely to be cured of your cancer if you have the inconvenience of a year of immunotherapy after the radiotherapy is finished.
Give us an overview of how survival rates have improved in the last decade or two, because they are much better, aren't they?
Yeah, they are much better. But again, the survival rate is all down to the stage of the cancer when it's diagnosed. So if I meet a patient in my clinic with a stage 1 lung cancer, I'm going to tell them that with radiotherapy, with stereotactic radiotherapy, there's a 90% chance of me eradicating that tumour. And then my job then is to keep an eye on them for the next 5 years and make sure the cancer doesn't come back anywhere else.
So your overall message for people who've smoked and for other people who've got any kind of symptoms at all would be what?
Would be to, if you're called for screening, please turn up for that screening appointment and be checked. Don't be scared. You've got expert people giving the results to you and explaining what they mean. The other thing is, if you've got a cough that lasts for 3 weeks, please don't just think it's going to go away. You need to go to your GP and be assessed and have at least a chest x-ray. Yeah. The other thing is other symptoms of lung cancer, things like chest pain, breathlessness, coughing up new sputum or coughing up blood. And they're the things that people perhaps take a bit longer to notice. But please don't hang around. I think any symptom that develops, that persists and deteriorates or get worse over time is something you should be concerned about and be going straight to your GP about.
Well, we'll take a short break there. This podcast is brought to you by Big Motoring World, one of the UK's biggest used car supermarkets. Their mantra is we're big on what matters to you. They're big on choice, service and value. They price check their cars every day to give a best price guarantee with up to 95% of cars priced below market value. Search bigmotoringworld.co.uk to find your nearest store and for terms and conditions. So let's talk about skin cancer.
Okay.
Another common thing. Now, the melanoma, skin cancer, is the worst one, the dangerous one.
Yes.
Something like 21,000 cases a year at the moment.
Yeah, it's usually, and it looks like it's going up, doesn't it?
Well, absolutely. It is going up. It's gone up, in younger people, it's gone up 7% in the last decade, and more than that in the older population, presumably because as they were getting older, they were taking more holidays in sunnier climates, getting sunburn. And I don't know whether this is an accurate statistic, but I heard that if someone in their lifetime has been sunburnt 5 times, it doubles their risk of melanoma.
Is that right? Golly,
so most of us are in that, and half of Britons are sunburnt at least once a year. So that would go a long way to explain why too much sun exposure, whether it's solar radiation or sunbeds, is increasing this problem. Now, melanoma is a nasty cancer to have.
Yes.
You deal with it all the time.
I do.
What's the bottom line here?
The bottom line is, if you have a mole that's changing, so the checklist for melanoma is the A, B, C, D, E. I'm sure you talked about your patients about this all the time. So A, if you're seeing any change in the appearance of your mole, you need to get it checked.
Yeah.
B stands for border. If the border of a mole has become irregular, you need to, or sometimes it just gets a bit blurry, it becomes a bit indistinct, go and see your doctor and have it checked out. C's for colour. And people think, oh, it's not getting darker, so it can't be serious.
No.
But actually, melanomas can become paler. You can see new colours being introduced. So like a bluey tinge or a reddy tinge, that's important and needs to be checked. D's for diameter. And the rule of thumb for this is that pencil, the rubber at the end of your pencil.
Yeah, that's it, yeah.
If your mole is of the diameter of that rubber, it probably needs to come off and be checked out what it is.
Absolutely.
And E is evolution. And we're back to that thing. Anything that's changing, anything that's getting worse rather than better needs to be seen by.
Because I've talked about these symptoms and that checklist for so many years.
Absolutely.
And people still aren't listening, unfortunately, because we're still seeing so many cases. And it's interesting, isn't it, that men tend to get their melanomas in different places on the torso. Particularly, whereas with women, it tends to be on the lower limbs.
Absolutely.
Partly because of the sun exposure and the clothes they're wearing. And of course, probably still people aren't wearing a strong enough SPF factor.
Do you know what? I'm really embarrassed. I didn't start wearing a regular SPF until I started treating skin cancer.
You and me both, yeah.
And it was the dermatologist said to me, what on earth are you doing? So even in winter in London, I've got at least factor 30.
Have you? That's
always
interesting. And this is because of what you see?
It's because of what I see. And it's not just the melanomas. I treat non-melanoma skin cancer as well. And I see people coming in with BCCs. So if you're going to get a cancer, you want to get a basal cell carcinoma. Because it's not the sort of cancer that jumps around the body. No. But left untreated, it's very locally destructive. And I saw a patient in my clinic last week who'd lost the tip of her nose because she'd completely neglected this BCC. It'll go away, it's fine, it's just a scab. And it wasn't, it was a basal cell
absolutely.
carcinoma.
It's often attributed by patients, so I was bitten by an insect. And of course, you see it evolve, you see it getting slowly bigger. I remember one of those pathology specimens that we don't see so much in medical training anymore. It was the Wellcome Museum, and it was an 18th century sailor who'd lost half his face. Because we used to call them rodent ulcers.
Absolutely.
And it's an ulcer which it's like a rat nibbling away, getting bigger and bigger. I saw another guy who was an agricultural worker who'd lost half his ear.
Yes.
And he was such a stoical guy. His notes were wafer thin, and you knew that the guy with wafer thin notes coming into the surgery is going to be something wrong since he'd come in. And he'd lost half his ear, and I had to persuade him to go and have treatment.
And did he have a good result?
Yeah, absolutely. Absolutely, which you do with BCCs. And they are so very common.
I mean, one of the bugbears for me is I think people forget that radiotherapy is a really effective treatment for these things.
They're a bit scared of it, aren't they?
Yeah, they are a bit scared. And I met a patient recently who had been to see a surgeon and had a squamous cell cancer of his pinna, of his ear. And he was told he's going to have to lose, 2/3 of his ear. And actually, I gave him 5 treatments of radiotherapy over the course of a week. And, the chance of cure is over 90%.
Fantastic.
And he keeps his ear. He can still wear his glasses.
Oh, well, that's good. That's good. That's what ears are for, after all.
Yeah, absolutely.
So, with melanoma, we know that it has the capacity to spread, even if it's quite small. I think Bob Marley he died of melanoma on his big toe.
Okay,
I believe it's a sort of famous a bit of knowledge. Melanomas can spread around the body, and we lose some young people every year. About 2,500 die of malignant melanoma. Too many.
Yeah.
What are the treatments now for melanoma? Because, people used to think, well, if it's spread, there's not much we can do because it doesn't really respond to radiotherapy very well.
Yeah, and melanoma is one of the great success stories of immunotherapy and targeted therapy. So we're back to that personalised medicine that we talked about earlier. So when I was a registrar, so this is not that long ago, if I met somebody with melanoma, it was a really difficult conversation because the treatments that you had were really toxic. Old-fashioned chemotherapy has lots and lots of side effects, and it didn't really work. So it was a really awful conversation to have with people. Whereas in the immunotherapy era, I'm telling people, there's a 50% or even just slightly over 50% chance that you're going to be a long-term survivor, even with melanoma that's spread throughout the body. And, you give them 1 or 2 cycles of the immunotherapy. So that's an infusion, a drip, say every 3 weeks. And you see the melanoma just melt away and disappear and not come back.
In all cases or majority?
Unfortunately not, and one of the very sad things about melanoma is I usually say people, look, it's going to go one of 2 ways. It's probably in 50% I'm going to see a very rapid, excellent response. And unfortunately, that other 50%, I'm just going to see the melanoma continue to march on. Right. And that's when we go back to the personalised medicine. So at that point, if they didn't have a genetic mutation that was driving the cancer to begin with, I'd then look for another one and then see if I can repurpose other drugs to treat the melanoma as it's progressing.
Do we know why it's so aggressive, melanoma?
I'm not sure we do. But one thing that is interesting about it is just how immunogenic it is. So in some people, it's very good at just provoking an immune response. And I think it's with tumours. I mean, the reasons that they respond to treatment is so varied, isn't it? And it's not just about the genetics of the individual cancer; it's how it interrelates with all of the cells around it. So it's the blood supply, the nutrients that it's able to get from that. Even we think that the microbiomes, so the bacteria that are living on the body, can influence how you're going to respond to treatment. So sometimes I see people, particularly on social media, trying to drill down. Oh, if you exclude this from your diet, you're going to do much better with your cancer treatment. Okay. And I understand why people do that. We're all looking for hope. We're all looking for things that we can do to get the best from our treatment. But it really oversimplifies what's a really complex system.
Yeah. But the majority of these skin cancers are preventable, aren't they? We're talking about SPF sunscreens, very important.
Absolutely.
And staying out of the midday sun that the Brits don't often do. That's important. But with these non-melanoma skin cancers, we've got some very effective anti-cancer creams now that can just be applied for a few weeks at a time. They're pretty effective, aren't they?
Yeah, absolutely, particularly if it's an early stage one. So if you've got a very superficial skin cancer, we have some creams that you can put on, and even things like light therapy, which will be, very effective at eradicating that cancer. So make sure that, if you are diagnosed with the cancer, you explore all the options. Because every patient we meet has got different priorities, haven't they? Yeah. So you've got to work out what works with their lifestyle, what's balancing the likelihood of cure against what side effects they're willing to tolerate or able to tolerate, and it's a dialogue, isn't it?
Yeah, absolutely. Well, look, we've covered lung and skin cancer. I know you look after other cancers as well.
Absolutely.
But what I'm getting from you is that early detection is so important. Prevention is so important. We've got better treatments, targeted therapies, personalised medicine. So the future is bright, and there's more and more research being done. We're going to get better results in the future, but we can't be complacent.
Absolutely. And I see my aim as an oncologist is not just to give the patient the best chance of cure of the cancer, but also to give them the best quality of life and keep them as the unique person they are without horrible side effects from the treatment I'm giving them.
Very good positive messages, James. Thank you so much for joining me.
Thanks. Nice to meet you.
Don't forget, you can watch all my interviews on the Dr. Hilary Show YouTube page, including my recent conversation with audiologist Laura Ewan. But there is a lot of noise pollution, and of course, younger people are playing personal devices at a very loud volume. And I think it's true to say, isn't it, that if you're sitting on the train opposite somebody and you can hear the music they're playing, they're damaging their ears.
Yes, definitely. Even on the way here today on the tube, I could hear several people's music all coming through their headphones, and I really wanted to stand up and tell everybody, turn it down. Heading here, and we're pushing the 60-60 rule. So we want everyone to follow that. And that is listening to headphones or a gaming headset at 60% of the volume for no more than 60 minutes at a time. Take a break, have a little rest, give your ears a rest, and that really will make a difference to protect your hearing.
Once again, don't forget to subscribe on YouTube. Do it right now. Make sure you watch the next episode, and let's talk about what really matters to you and your health. And for more information and show notes on all our programs, just go to drhilaryjones.com.